And then we'll just crop it later. It's fine. Multiple witnesses that we've actually pressed record. And this little thing is blinking, so we're good. Hello. Coffee. Oh, it's like New Year's Eve. Yeah. Oh, wow. That is a lot of great foods. And a whole honey bear? Honey. Oh, that's water.
I know that's a little high risk. The person just like hot water.
I didn't even flip the bar.
I almost did it too.
I've already eaten my fancy one for the week. Oh, so your class went well?
Yeah, it was so fun.
Good.
The people were so nice.
Okay, hey everyone. Oh, this is just this is Perry's video camera. Oh, I'll turn the video camera on. Okay. And maybe I will, can I unblur my background so that you could see who's behind me? Oh, let's see. How do I do that from?
You have to click on video drop down. Like, you know, where it says start video.
Uh-huh.
Yeah, there's like a little drop down arrow. I think that's video setting.
Oh. I see what you're saying up here. Got it.
Yeah, that.
Unblur. There we go. Thank you guys. Thank you guys. Okay. So in case anybody bombs us, we're just gonna minimize that. So who was there on Monday? Few of you? Okay. Many of you. Okay.
Keep sorry.
I'm sorry. So yeah. What? This is the same thing. I was just asking who was there. Our special friend on Zoom. So thank you guys for letting me swap out or fill in one of the bonus soft tissue sections with parathyroid and thyroid, because we have my friend and mentor, Dr. Peter Sadow here from Mass General, which is now Mass General Brigham. Aren't you glad you're not there? So he was here to teach yesterday in the thyroid CPP with me, and decided to hang out for another morning and chat with you about endocrine paths. So I know I gave you so thank you. And I know I gave you the initial slides kind of late, so I apologize, but you guys did so amazingly well on the spot frozens for the past couple days that I figured you'd be just fine. You guys are awesome. As you can see, if you looked at the unknowns, there were a few parathyroids and then many thyroids. So the clinical history will go through each one. I am assuming you could probably guess the clinical history. In these cases, it's not very sneaky. But I will start with some paras, and you may remember some of these cases, or you may not. But I wanted Peter to before I began, talk to us a little bit about the parathyroid freezing practices that they have at MGH, because it's a little unusual and you may or may not see this when you go out into the world, and I wanted you to have an
I'm
approach
just rotating.
for
a
it.
little bit back. No, it is, we do a little bit of a strange parathyroid freezing practice that I don't actually participate in, but I'm the only one who does it because I'm morally opposed to it, so I don't do it. So I do a similar one, I imagine, to what you do here. But one of the things that you can employ during a frozen section for parathyroids is a stain called oil red O. And oil red O is a vital stain that will stain lipids. And of course, the lipids are lost after you fix it in formalin. So it allows you to intraoperatively see the fat. So if you're looking to see like percentage of cellularity of parathyroid, if you're looking to say it's X percentage, cellular, or looking to say whether or not there's intracellular lipid, which can tell you how functional the lesion is or not. It may be useful. Want to come in? Sorry, I'm just blocking the door. Not on purpose.
You're not allowed. Get out.
Yeah.
Just kidding.
Sorry.
It's fine.
And so a lot of people do it. Sometimes it actually helps you identify, like, for instance, some parathyroids can look fairly follicular appearing. So sometimes it actually helps you identify that it is parathyroid. I'm not a person that says you should never, ever use it. But one of those things is, if it's not physically there, you can't use it, right? So that's the idea, is that people use it so that people will keep using it, but I'm not interested in it. But other people do it, they start saying the percentage of the cellularity, but of course you're only seeing a snapshot of it, and in a permanent section, you can see it without actually employing the oil red O. So it's a question of what you actually do frozen section for on parathyroids, because hyperparathyroidism, actually the surgeon should know ahead of time, right? They're doing a surgery because the patient has hyperparathyroidism. So the purpose should be to identify that you actually have the tissue. So it's like, oh yes, here's a hypercellular parathyroid, you found it. If the surgeon is concerned that it's multi-gland disease, they can freeze more than one parathyroid, and you can tell them, yes, you have more than one hypercellular parathyroid. Or if the surgeon thinks that it's a parathyroid adenoma, they can biopsy or take out the adenoma, and they can biopsy the other normal parathyroids, and you can say that it appears to be normocellular parathyroid. So you can do that without actually using the oil red O. But the majority of the faculty at my hospital will use the oil red O, and then I get it permanent section. I have the intraoperative oil red O, and I ignore it, pretend it never happens, and I don't report it. But I mean, I'm actually the only one that does that, but because there's no reason. Actually, at some point, I wrote the chapter in this Sternberg, parathyroid thing. I said no utility. And then my department still will use the oil red O. I can't. Nothing I can do about it. Old habits, I suppose.
Interesting. So thyroid shouldn't have intracellular fat. So you use it in that context. Is that what you're saying?
Thyroid should not have
Okay.
intracellular fat.
Cool.
So if the differential diagnosis is this thyroid or parathyroid, it
Cool.
can be helpful. But the truth is, if it's really tough, it's really tough anyway. Like, you can also do polarization and look for crystalloid material in the colloid of thyroid to help you make that differential. And if you can't, sometimes I'll actually just say to the surgeon, I don't know, it's either thyroid or parathyroid. I'll tell you in permanent. They're like, fine. Usually, they're fine, because they clinically know what's going on with the patient. They know where they are. They know what their differential is, and you're kind of affirming that typically.
Cool. Thank you.
Thank you.
We don't really, I mean, we have a oil red O, I think, in histology, right? But we don't really use it in the frozen room, and you can't use a fat stain on formalin fixed tissue, right? Because the fat has washed out. So it has to be on fresh frozen, cryo cut tissue. The times where I think fat stain I would have liked to use is actually in differential diagnosis of something like sebaceous carcinoma, where you might want to see intracellular fat, and we don't have like the adipophyllin stains or whatever. But then most of those cases are formalin fixed paraffin embedded, so like it's too late. So if you ever have a suspicion for sebaceous, you could take a piece from the fresh specimen and keep it in OCT frozen, but it's already fixed then.
And that actually is the one case scenario, and this actually doesn't happen at Mass General. It happens at Mass Eye and Ear, because the sebaceous carcinoma is often found in the eyelid.
Mhm.
So we'll get IPATH for ophthalmic pathology frozens, And if the concern is sebaceous carcinoma, then we'll go ahead and use the oil red O stain. So we do keep it also at Mass Eye near the stain. We have it both hospitals. And I don't use it for parathyroids, but I will use it in a sebaceous carcinoma because they're sending it for margins, which they shouldn't send. Can you imagine if you're working in an eyelid and you're taking out, excising a small tumor? They're literally sending a 2 millimeter specimen that has a suture in it and it's oriented and like, can you please do the margins? And then you can see my middle finger extend very quickly. And I tell them that I'm not a Bose lab and then I refuse. I'm like, if you want, you can ink one end of it and that's the end of it, but I will use an oil red O in that particular case. And again, even if it's challenging, it doesn't matter. We do have the adipophyllin, which is new. It's sort of recently emerged like in the last 7 years or so, immunostain that even after you fix the tissue can see fatty stuff. So you can do that on permanent section, but intraoperatively, if you're trying to do margins for a sebaceous carcinoma, then oil red O intraoperatively can be helpful, but it's tricky, especially if it's a really tiny biopsy.
Cool, thank you. Did you just mistakenly pour the hot water also? Yep. Cool, thank you, Peter. That was good. Okay, so let's get back to the screen share. Where's your screen share? Okay. Cool. So we can minimize ourselves. And you guys may remember this case from, there we go, from the session, but I wanted to show it to you again in kind of a little bit of a more deeper context. So we've got a mouse. So who wants to drive it? Rehum? You're right in front of me.
Okay, that's fine.
So the patient has hyperparathyroidism.
Okay.
You can ignore the dots, it's fine.
Okay. So from this magnification, I'm able to identify thyroid. And then,
Brilliant.
Yeah.
Thank you. Show us the thymus.
I missed the brilliance. What was it?
She identified thymus from very low power. I every time I see even the tiniest little fragment of thymic tissue, I'm like, what is this? So, and mostly I've gotten them to learn to identify thymus.
thank you for the input.
Mhm.
Then, yeah, so here we have the thymic tissue, and tissue there. And then we have parathyroid. There's kind of, I don't know, is this a capsule?
Maybe,
So we have two parathyroid,
probably 2 halves of
okay.
a gland. Mhm.
Yes,
Mhm.
and so I'm able to, well demarcated, and I'm not sure if this is capsule or, and I'm going higher.
Kind of almost maybe retracted from the
Yeah.
capsule, or there's a cystic space.
Yeah.
Mhm.
And what are you looking for
So
when you're going higher?
I'm trying to check the psychological changes and if we have any mild. And if we have any invasion to the surrounding tissue.
Okay.
So here it seems for me very well circumscribed, no invasion. And it seems like there is mark here and mark here and here. So.
Yeah, it's fine. Just ignore the marks.
Right?
Ignore the marks and not made by her. Mark.
Oops. Next time we'll wipe the marks off. Woo, yeah, look at those cells.
So
So in terms of the architecture, what else, sort of at low power, what else are you looking for that you haven't seen?
it's monotonous, like it's just one subtype.
So in terms of that discussion about the oil red O,
Yeah.
one of the things you're looking for is fat, and you're
there is
not
no
seeing
fat.
any fat,
Yeah.
right? So the other thing is you're looking at the periphery of the lesion to see if you can see a normal cellular area. to let you know that this is an independent neoplasm, potentially. Doesn't guarantee that without looking at the other glands, but you're just wondering, is this potentially a parathyroid neoplasm? And one of the ways to see that is to see normal parathyroid adjacent to the actual solid area. And that's one of the things you look at low power. And if you don't see it at low power, you might zoom in to see if you see it kind of compressed against the edge somewhere there, and you so far haven't been able to find it necessarily.
Yeah, so it seems like it's more tumoral than hyperplastic. And there is no fatty tissue. And it just one cell type, and I'm not able to identify a normal parathyroid tissue.
There's a little crumb, I think the last night I remember, is there just at the bottom? Like if you go down, is that a little crumb of normal or
Yeah,
multiple little crumbs of normal parathyroid? Along the, maybe not, maybe not, never mind.
I honestly don't think I was able to see any
Is it
normal.
just looks like-
Yeah, I think
Okay,
it's just
so
ectatic
maybe it's
spaces
a
rather than
different-
fat.
it's a different case.
Could have been a different case. Yeah, there were a few. Mhm.
so I feel like we have two patterns of cells. So here it's more cytoplasm, voluminous cytoplasm, eosinophilic, and like two different type of cells.
What does that tell you? Seeing the two different types of cells.
It's not tumor, it's like,
Oh, it tells you nothing. But it does give you an indication that there's nodular change in the parathyroid. So it's hypercellular and it's nodular. And you see hypercellular nodular change, you can start thinking about things like multi-gland hyperplasia when you see that pattern, but it may not necessarily be reflective. So then when you look at a cellular parathyroid, and you've already mentioned things that you don't see atypical mitotic figures, you don't see it infiltrating into the adjacent tissue. There's nothing about this particular thing that's telling you that it's malignant, which is really difficult to tell it's malignant anyway, even when it does do things like that. But it tells you it's not malignant, but the fact that sort of nodular hyperplastic changes makes you start wondering, what do the other glands look like? And that's kind of where you are. And then if you actually have this, and you have the patient's has hyperparathyroidism, then if you were making a diagnosis, and this is all you had for the whole case, you would just be able to comment about the fact that it's a hypercellular parathyroid, parenthesis, weight, whatever it weighed,
yeah.
periods. And does anyone know the normal weight of a parathyroid?
20 to 40 milligrams.
Yeah, so it's typically sort of, you think about 50 milligrams as kind of being upper limit of normal of a parathyroid. In this particular case, it would weigh more anyway, which is why thymus, right? It's not parathyroid alone. And sometimes it comes with a chunk of thyroid attached to it too. So sometimes the weight can be a little bit deceiving, but you think about a parathyroid alone as being sort of upper limit of normal is about 50 milligrams. So anything more than that's enlarged. So you can say it's an enlarged hypercellular parathyroid, and then the likely going to be getting intraoperative PTH levels. The thing is that even patients that have multi-gland hyperplasia, you can get a dominant nodule, which actually suppresses the other parathyroid glands. So they're not large by looking preoperatively, like at a 4D CT scan or something like that. And that if you take out a sort of dominant nodule, the intraoperative PTH will drop after they take out the parathyroid. So it looks like, okay, we have my adenoma, it's out. And the patient presents 3 months later with hyperparathyroidism, because now that you've kind of taken away mama, the baby that expresses itself, and the next thing you know, you have another big parathyroid. So that's one of the caveats in a single gland when they take it out. But that's kind of the types of things you need to keep in mind.
All right, I'll take that thing back. Thanks. So thank you. So, I mean, I think that one of the points, right, is that there's a lot of clinical pathologic correlation with parathyroid disease, and there's only so far we can go on histology to identify the background clinical framework in which these parathyroid lesions occur because of these confounding scenarios, right? But the one interesting thing that ended up happening with this case is one, you note this multiple cystic spaces within the parathyroid. Just note that they're present. It's not necessarily specific, but it becomes important at some point. You already noted this shift in cytomorphology from this population of kind of relatively round monotonous cells, which is what you kind of would expect in a normal, run-of-the-mill hypercellular parathyroid, whether it's an adenoma or hyperplasia. And you correctly identified this sort of shift, like right here, whoop, like what's going on here? And so we know that in the parathyroid, we can get chief cells, oxyphil cells, clear cells, but do these, what the heck? Do these normally look like the conventional oxyphil cells of the parathyroid? Usually those have brightly eosinophilic cytoplasm, right? Very much like oncocytes, rather than this almost amphiphilic cytoplasm.
I'm gonna kill you. This is what you shoved in here.
And, yep,
I know
Yep.
what it is now. I'm like,
You're like,
to me, it was parathyroid.
Yep.
None of you actually thought it was not. I mean, the parathyroid.
no,
Be fine. I would have signed.
no, it's still I'll show you, it's still parathyroid, but these nuclei start to get weird, like grooves. Okay, there's like weird grooves in the nuclei. That's a little bit unusual. There's some random endocrine type atypia where you start to see a nucleus here and there and enlarge, but that's okay. Like that's okay for parathyroid. All right. But overall, these cells are a little bit different. The nuclei are bigger, right? The cytoplasm is more abundant and kind of granular. And if you, unfortunately, this is being a little slow, but you may want to look around and start identifying that the chromatin may becomes a little bit coarser and chunkier, and you may or may not see nucleoli that are slightly more prominent. And so just this odd shift in morphology, I was like, I don't know what's going on. Number one, is this parathyroid? And if so, why is it different, right? It's more different than the usual, like, these are just oxyphil cells, right? Like they're not. So let's, what would you want to do any stains?
We
And-
went with that attitude.
And why?
And also.
and there's two listed here, so yes.
Yeah. And what clinical information were you given?
Just hyperparathyroidism. That's it. That's it. Just like we get with everything, the patient has hyperparathyroidism.
I mean, I know what the people have now, but that's a little shame.
Out on the side.
All right, neuroendocrine markers for paraganglioma,
Thyroid.
thyroid. Okay, so this is I just went straight to the PTH stain. We don't have it anymore, but Mayo does. So I sent this to Mayo just for PTH to determine that this was actually parathyroid tissue.
Yeah.
And like it is, right? So there's PTH in the background, and then there's PTH in the funny looking cells, even though the funny looking cells are a little bit weaker. And then, so this is parathyroid. So then how do you account for this cellular atypia? It's not invasive. I agree. It's not invasive. Like this is not invasive. So I'm not going to call it carcinoma, but what is the implication of this unusual cytomorphology? So there are now these neoplasms that are short of carcinoma, but cytologically and architecturally worrisome for potential bad, quote unquote, bad behavior, meaning potential recurrence and potential germline syndrome in the patient. So what stain am I showing you now?
Parafibromin.
This is the parafibromin, right? So you can see retention. We'll talk about what this is in a second, right? But you could see retention of the parafibromin in the background sustentacular or vascular endothelial cells, and essentially complete nuclear loss in the neoplastic cells. And it's diffuse. It's in both populations, whether it was the small monotonous stuff or the unusual cytology. So what's the implication of this? Who remembers? Mm-hmm. 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 What's the gene? It used to be
CD7.
hyperparathyroidism jaw tumor, HRPT2, but now it's CDC73. Okay, cell division cycle 73. Okay, CDC73 is the gene. Parafibromin is the protein. These patients have germline CDC73 mutations and then subsequent sporadic biallelic loss, resulting in these parafibromin loss neoplasms. And the consequence is kind of twofold. The consequence is, one, this unusual cytomorphology can predict parafibromin loss. Parafibromin loss can suggest potential germline CDC73 mutation, right? So these patients should undergo or should be offered to undergo germline screening because it has implications for themselves, their family, whatever. They may end up developing increased risk for actual parathyroid carcinoma, but you shouldn't make a diagnosis of parathyroid carcinoma based on this. You should suggest that this patient is at risk for development of other parathyroid neoplasms in their other glands and potentially parathyroid carcinoma at increased rates than the normal population, and jaw tumors, right, which are basically ossifying fibromas of the jaws. So the implications of this are not in a cancer diagnosis, but in a cancer syndrome screening. So this was the importance of this case.
How old is this patient?
This was do you remember? It was like a young 20, 30, maybe.
So
It wasn't
that's the important thing.
it wasn't a really young or really old, but yeah.
Because most sort of people that have hyperparathyroidism, like especially in women, every endocrine thing is in women. So let's just start there. As they get older, it becomes more pronounced. So the hyperparathyroidism in women tends to be like a 60s, 70s type thing. You can typically follow them clinically and they don't need to actually have surgery. And then if you start following the calcium levels when they start having issues, then you actually might want to go in and do exploratory surgery and take up. If the patient has multi-gland disease, oftentimes multi-gland disease is a result of kidney failure or kidney problems. And then you can start figuring out the level of the kidney problems, primary, secondary, and tertiary. And then if it's actually a primary thyroid problem, if the patient's young and has this problem, the patient's in the 20s or 30s, then you start thinking about these things more. The fact that I almost went down the rabbit hole. I did go down the rabbit hole in this particular case. I may or may not have noticed this because I just like to move along. And if I didn't notice it, honestly, the patient would be better off. So the point being is that with the parafibromatosis stain, which is the protein expression of the CDC73 gene, it does let you know exactly, as Nicole explained to you, about the patient's risk for having a germline lesion, and you may call this an atypical parathyroid tumor, even though it doesn't actually have the classic features of that. But at the same time, it's sort of like setting the patient up for a world of hurt. So if you're making the diagnosis early, then it's helpful. If this patient is a 70-something-year-old person and you start like going down this route, it's of no benefit to the patient. Meaning patients that have this syndrome, the hyperparathyroidism jaw syndrome, typically present with ossifying fibromas at an earlier age. So their first presentation would not be a parathyroid lesion, it would likely be the jaw lesion because they can actually feel that and it causes some issues, and then they have that, and then this added together would give you clinical suspicion. And then you can do this, and then of course they follow the patients for genetics. But in this particular case, you'd have to be worried about parathyroid carcinoma, meaning that in this particular case, the low power isn't, and probably the cyst probably has something to do with it. If Nicole is discussing it, I have no idea. I'm like, really, this is the child teaching the senile parent. But if you were looking at this, and you were really worried about this, you'd see broad bands of fibrosis. You would see irregular, periphery of this lesion. You'd be worried, like the typical diagnosis of an atypical parathyroid tumor, formerly known as atypical parathyroid adenoma. And this is a little bit weirder.
Right, yeah, because this is a different patient. Yeah.
Okay.
Did they send that for frozen or anything?
The top one, I don't think they did, and it was a 23-year-old.
Yeah, so that's where just because when it's a younger patient, since there are implications, you would be more likely, especially it's just very unusual for a 20-something or a late teen to develop a parathyroid lesion, period. So that's when you actually have a higher index of suspicion for something a little bit nefarious than you would if the patient, from 50 plus.
Right. Yeah, I think the only couple parafibromatosis lost neoplasms we've seen have been in younger people, either teens or 20s. And an example of a parafibromatosis retained neoplasm is this. You can see it also has the cystic spaces, which are a low power cue that this might be one of those. It has fibrous bands, okay, but the cytomorphology doesn't have these kind of large cells with that abundant cytoplasm and that coarse chromatin. So those are the features that you want to be looking for: the cysts, fibrosis, coarse chromatin, abundant eosinophilic cytoplasm, sometimes with halos. And then this was just an example of a parafibromum that we sent out that was retained. It should be, I think this is an artifact that the center is kind of negative, so ignore the center. But any retention in any of the lesional, cells is implying retention in the whole thing. Like it's either one or none. So this is retained. So this was not one of those, but we sent it anyway because of that architecture. So just
And I just,
keep in
and
mind.
I don't mean to add additional skepticism, but
Mhm.
we actually have this stain
Mm.
and again, I'm like the only one who doesn't do it. It's not because I miss these lesions.
Mm.
But the reason is that it's a very finicky immunostain and it
Yeah.
depends on the lab. We had a case once in 2010 or so where and the only reason I date it is because it's a person who's now retired that's no longer, the person that actually found this parafibromatosis stain is this guy named Ron DeLellos, who was at Rhode Island Hospital at Brown. And we had a case that in the frozen section, one of the people thought was suspicious for lymphovascular invasion. The question was, is this parathyroid carcinoma?
Hmm.
And I got it. I'm like, no, this is not parathyroid carcinoma. And but it was the person on frozen said it was suspicious. And on permanent, we did the parafibromatosis stain. The parafibromatosis stain was lost. So like, oh, the parafibromatosis stain is lost, which if parafibromatosis stain is lost, in the differential diagnosis is parathyroid carcinoma versus atypical parathyroid tumor. And if it's retained, it could also be atypical parathyroid tumor
Or carcinoma.
or carcinoma. And the point of this is because, so then the surgeon, because the person on frozen thought it was carcinoma, and I was not thinking it was carcinoma, said, could you please send this to this guy in Rhode Island who made the stain, Ron DeLellos. So we did. And Ron DeLellos said, we titrated our antibody and had shown that the parafibromatosis stain is indeed retained, even though ours was lost.
Oh,
He said it was
interesting.
retained
Wow.
and said, however, I do think that frozen section was lymphovascular invasion and I call it parathyroid carcinoma. So then at that point in time, I never did the stain again because like he said it's retained and he's calling it parathyroid carcinoma. And of
I
course,
just love endocrine pathology.
and of course the tumor never recurred because it was not
Not
parathyroid
carcinoma.
And I was right, but it's now long enough later that if it, since it's over 10 years, that if it was actually parathyroid carcinoma, it would have recurred.
Mhm.
So that's why I think some of this stuff is a little silly, even though in a young person like this patient was, even though I missed it, a young person like this patient actually can be diagnostically and prognostically helpful.
Thank you. Yep.
How often is it that the biallelic block get the same allele, or is it like a separate inactivating mutation?
It's usually I believe it's a separate inactivating mutation, or I don't know if it's a segmental loss of the chromosome. It might be also segmental loss. Mhm.
What is the actual likelihood of them getting parathyroid carcinoma with the?
The
It
likelihood
is,
of anybody getting parathyroid carcinoma is virtually none.
it's increased compared to the general population, but it's not astronomical. I have the number somewhere in that presentation, but I don't have it in my head. So yes, it's increased, but it's not astronomical.
Let's say it is parathyroid carcinoma.
What are they gonna do differently? Nothing.
Exactly. It's like,
Is anybody sequence those parathyroid carcinoma versus just a typical versus this adenoma? Do we know what's the difference molecularly?
Other than the parafibromin,
Yeah.
CAC 73, I don't know.
you're asking about additional hits to the,
Yeah.
I mean,
Yeah.
some of them have P53 mutations in addition. It's the issue ends up being is that since it's a diagnostic threshold for parathyroid carcinoma, and truly, I mean, it's truly the only diagnosis is metastasis. And it also has to be not local metastasis, it has to be distant metastasis, because
Right.
the idea of especially in atypical parathyroid tumor that may be infiltrative a little bit or like kind of have.
Or parathyroid.
It causes
Mitosis.
parathyroidamatosis, which is recurrent. So essentially parathyroid. So the reason why when you do parathyroid surgery, you can take a little piece of parathyroid and shove it in the arm or shove it in the platysma muscle and it develops its own blood supply. So if you leave a little bit of the parathyroid tumor in, which is actually already over functioning, it's going to have growth into the neck. It looks like infiltrative carcinoma at that point, and it's literally not, but it doesn't matter. It still behaves as a bad actor. So unless it actually metastasizes distantly, like to the brain or to the lung, you can't actually
We had a one case of lung metastasis.
Yes,
Yeah.
like doesn't everybody like has one or two cases, it's super rare. So then the idea of what is the molecular profile of parathyroid carcinoma? Well, it depends on the threshold of the person making the diagnosis, because you actually take true parathyroid carcinomas that have metastasized. You'd actually have to collect them from multiple institutions over many, many years and then do a profile, which they haven't done.
Okay, let's do it.
You know,
What?
get on it.
Get on it.
Is it important though?
Is it important? No, because they treat parathyroid adenoma, atypical parathyroid neoplasm, and parathyroid carcinoma the same, which is by debulking of the disease, because there's no actual other medical treatment than just surgical. What?
Regarding morphology.
Yeah.
As you remember.
Yeah.
When I long time ago was
Yeah.
signing out at.
Oh, yes, when it was general.
I was collecting all this parathyroid.
Yes, you have a gallery.
Because I was fascinated with morphology of parathyroids, and I had a whole gallery of.
You probably have some weird ones like this.
I do, that's why I'm telling you.
Give them to her.
And I was, actually, I gave it to her because we
She
wanted,
doesn't remember?
no, we wanted to submit for USCAP as some kind of
Art
artistic.
project, yeah.
art project.
When they, remember when they, one year they did the art show?
Yes, they did.
Yeah,
But what happened? We didn't do that. What-
I don't know if we did it or not. I haven't seen it. We'll unearth the file and we'll do something with it.
There's a lot of blank walls out there.
There's a lot of blank wall. We could parathyroid up the walls.
That will grow with environment.
Okay. So nice. I just wanted to briefly show you in contrast, something that is atypical for different reasons. And that is the intersecting kind of fibrous bands, very, very solid growth. This actually was a recurrence from a patient with a multiply recurrent parathyroid neoplasm that actually may actually be or end up being metastatic / carcinoma, right? But this has sheets of cells, again, with these perinuclear halos, right, which is kind of, again, suspicious potentially for parafibromin loss. I think this was an older case. I'm not sure if we did it on this patient. I can't remember. But this is actually showing this kind of maybe trickling kind of infiltration or even maybe lymphatic invasion into the skeletal muscle here. So this is actually perhaps a little more worrisome for true small nested infiltration as what you might see in a parathyroid carcinoma with these kind of fibrous bands. So just kind of the various morphologic spectrum of parathyroid and what like things you should be looking for. Again, the patient, you may not actually change their immediate treatment, but you may change their risk for recurrence or their kind of syndromic association if you can report some of these things. So that's kind of all I wanted to say about parathyroid. Did you have anything else?
Yeah, I mean, I've had, so the cases I've had of true parathyroid carcinoma, at least that I've been sort of willing to suspend my disbelief,
Right.
is seeing like overt invasion, like you're gonna see overt invasion into thyroid, adjacent thyroid tissue,
Mhm.
where you actually have linear invasion of growth. Because one of the other things too that we sometimes, the parathyroids can sit on the thyroid. So when we take sections, we take a slice through it. So it's a two-dimensional section. So it can look intrathyroidal, but it actually is sort of abutting the thyroid. So the section that you actually take looks like it's in the middle of the thyroid tissue, but it's actually not. It's just adjacent to it, but you cut through it at an angle so that it looks that way. But at the same time, if you start seeing infiltrative bands of tissue going through the thyroid, that's not abutting the thyroid, that's literally invasion. So I've called parathyroid carcinoma based on seeing stuff like that. The things that Nicole just showed too, I mean, at least the architecture was really worrisome. But the things that she mentioned, like, you know, possibly lymphatic invasion, those are the areas that we are really
Quibble
difficult.
over. Mhm.
Those are the areas that, you know, people have very subjective opinions that you'll show to one pathologist and they are overtly like, this is absolutely vascular invasion, that they're adamant about it.
Right.
And it's sort of like, is it though? Is it though? And so I think that you all should maintain a solid skeptical, you know, view of these things, even though you think it might be. And I think in a case like this, where it might be, and this one looks very strange. There's apoptotic figures everywhere. It is a little bit concerning. You know, the fact is multiply recurrent.
Oh, there's a
Again,
light. Mhm.
Yeah, again, could be, you know, worrisome.
High power, sorry.
That might,
Mhm.
there are actually two in this field.
Mhm.
You know why I'm doing this?
Why? Because you have galleries of this?
No,
Oh.
actually, I
He
had
does.
a thyroid carcinoma. I took the picture, I sent it to our head of pathology, and I said, what do you think this is? And not saying where it's from.
Uh-huh.
And the pathologist said, oh, it's chromophobia CC.
Nice.
Not bad. Normal.
Right? It's that halo. Exactly. That's hilarious. That's hilarious.
So I think, it's certainly, if you have a case like this, you're practicing and you see something like this, I think it's actually it's always okay to raise the possibility of, it doesn't do you any harm. Especially when it's recurrent like this. If it's recurrent multiple times, you know that the surgeon's on it, right? It's come back multiple times. They're aware that this patient has a problem. So it's not like a standard parathyroid surgery. The patient goes along their way and you never see them again. If it's recurrent, then they know. So what actually is the follow-ups for patients with parathyroid surgery is close clinical follow-up and re-excision, as Nicole has mentioned. So whether you call it carcinoma or atypical parathyroid tumor, whatever it is, they're going to follow up. If you say suspicious for carcinoma, at least it's going to trigger for the patient anxiety and everything else, but at least they'll also follow up, maybe.
Well, thank you. All right, we're gonna shift gears a little bit to this was a kid, right? This was like a 10-year-old with a neck mass. Here, Magna, you're gonna drive it. Thank you.
So here you see a biopsy at low power and looking at one of the pores.
A little finicky.
There's sort of this fibrotic myxoid stroma. And there's this basophilic cell population, which the nuclei are a little bit hyperchromatic, but there's no prominent nucleoli. And there's sort of overlapping in this focus, but in other areas, it almost looks plasmacytoid, and there in the stroma, there's a little bit of a hint of an amorphous material that I considered. Because we're in a thyroid session, I was thinking of what things could be, and I was like, well, could this be amyloid? So
Because it's a thyroid session, I'm saying, could it be medulloblastoma? Could it be?
but overall,
Granulosa cell tumor.
Correct.
I'm moving over to
Classic.
another
Sure,
core here,
sure.
just to kind of look at everything. But overall, I thought that the cells looked kind of bland.
Mm-hmm.
And they even made me think about the solid cell rest
Mhm.
in some areas, like here.
Mm.
And there weren't any mitoses that I appreciated when I previewed. Or very prominent nuclear atypia. So
If you were thinking they were solid cell nests, what would you also expect to see sort of accompanying now?
thyroid,
Thyroid. And you're not seeing any normal thyroid
No.
here. Right, so.
So there.
No. I'm saying.
joking.
So just, because this would be a lot.
Right.
Solid cell nests, I mean, and actually in some ways, it does look like that, it kind of the low power look to them, but there's a lot of it.
Yeah.
Yeah.
The only time I've ever seen this abundance of solid cell nests without overt thyroid parenchyma is when there's been some kind of thyroid ablation from like radioactive iodine or external beam radiation, and it's like shot the thyroid parenchyma, but it's kind of weirdly preserved like the solid cell nest structure. Yeah, have you ever seen that?
No.
Okay. I've seen that like
I mean,
once.
I theoretically can
Yeah,
imagine it, but I
yeah.
haven't seen it.
Yeah, I mean, maybe not to this extent, but yeah, okay. So what's your differential then?
so a medullary thing comes to mind. However, I would veer away from carcinoma because it looks kind of bland.
So what is medullary thyroid carcinoma a neoplasm of?
C cells.
C cells. So what other C cell lesion can you have that's this extensive?
Well, I was gonna say C cell hyperplasia was
Okay.
something else that came to mind.
Okay. Again, what are you missing? You're missing thyroid tissue.
Mhm.
And what do you have that would abrogate the diagnosis of C cell hyperplasia? assuming these are potentially C cells, because we see the plasmacytoid morphology, we've seen the stippled chromatin, we've seen the granular-ish cytoplasm, if you want to show us that. But what does this have that precludes the diagnosis of C cell hyperplasia?
All of this fibrosis.
All
in
of the
between.
background, right?
Yeah.
So that's not really allowed in
Yeah.
C cell hyperplasia. Exactly. So, okay. Cool. You're right. So it's, I mean, it ends up being medullary thyroid carcinoma. Okay. Here, I'll prove it to you. So here's, I think this is just a keratin and this is a calcitonin or vice versa. Yeah, that's actually is the info isn't here. I can't remember which is which. One of them is keratin. Oh, actually here we can tell based on the positive control. This must be keratin. This must be keratin because those are crypt cells. And this must be calcitonin. Yep. So this is calcitonin. Okay. So, you know, 10-year-old kid with a neck mass. I don't even think this was labeled as thyroid. It was labeled as neck, right? Because it's just, it's big. It's got this plasmacytoid appearance that you would expect in the C cell kind of medullary thyroid carcinoma realm. But everything is kind of granular and almost blurry, right? The nuclei are very kind of granular and blurry. The cytoplasm is kind of granular and blurry. There aren't prominent nucleoli. This is what you would expect for this kind of neuroendocrine type of differentiation, regardless of whether it's medullary or other neuroendocrine type neoplasia, right? This appearance is quite common. And so I didn't do Congo red because we were saving tissue for molecular, but in a kid, a 10-year-old, what inevitably, what does this patient have? Some kind of germline, medullary thyroid carcinoma associated syndrome. Exactly. So there's various ones of them that associate with various RET mutations. So now, I mean, obviously this kid probably has that syndrome, whether it's known or not, but we are testing essentially all medullary thyroid carcinomas for RET mutations for various reasons, including if there's a RET mutation in the neoplasm, the patient is eligible then for germline screening, right? Or various kind of therapies. And you were mentioning yesterday in class about the therapies for medullary for RET. Do you want to talk a little bit about that?
Yeah, so they have targeted therapies that actually work particularly well. I think one of them is called selpercatinib. They target specifically activated RET mutations. So the most common mutation for RET is M918T is the most common. The fact that this is a 10-year-old kid it's very highly likely to be a germline mutation associated with MEN syndrome. And then this question is, what is the extent of the disease? Because if it's known, they follow this patient, right, and then decide to take it out. They typically take out prophylactically the thyroid glands in kids that have known MEN mutations somewhere between the ages of 7 and 10. The reason why they wait that long is because also the parathyroids tend to be translucent in little kids. And if they take out the parathyroids, the kids tend to be in trouble. So they also want to be able to identify those. They follow the kids, they follow their calcitonin levels, and then they'll prophylactically take out the thyroids. And this is just a core biopsy of the tumor, but then it depends on the extent of the tumor, right? If this is a 10-year-old kid that has bilateral neck metastases, then the likelihood of it having escaped the region of the thyroid is higher and they'd be eligible for medication. So these medications work particularly well because they only target the activating mutation. So they don't have the other sequelae of other chemotherapeutic agents that destroy the bowel and cause your hair to fall out and other stuff. They're targeted. The only typical issues they have with these medications is they can have, as they're transitioning onto them, they can get some GI distress, and that typically is self-limited and lasts less than 2 weeks. And then they can tolerate these for long periods of time. If they actually have distant metastatic disease, then they can subsequently develop resistance mutations, of which they can add in then a secondary tyrosine kinase inhibitor that actually works particularly well. But the other thing that was mentioned about this was C-cell hyperplasia. And it goes like, how could you have C-cell hyperplasia in this situation? And that's correct. And even if you think about C-cell hyperplasia, it should be a collection of 50 cells or less of these parafollicular C cells, and you would see the normal thyroid around it. Even if there was normal thyroid around it and you saw like a collection of like 50 or so cells, if you saw a desmoplastic stromal response around it, it removes the diagnosis of C-cell hyperplasia. It literally means invasion. And even if it's a very small cluster of cells, then you'd have to diagnose a medullary thyroid microcarcinoma.
Mhm.
Okay, and that's the difference is sort of the stromal response in the thyroid to the tumor. Rather than just seeing, a collection of C cells. Because you can see C cell hyperplasia associated with benign disease. Patients with multinodular goiters, patients with an adenoma associated with it can develop C cell hyperplasia, and it doesn't indicate the patient has an underlying mutation.
What you're saying is the size doesn't matter if you see that's a plastic reaction.
Right.
Correct.
Yep. So if you see desmoplastic reaction or amyloids, any stromal reaction, that's microcarcinoma. Yep. So, we've seen these MEN prophylactic thyroidectomies for these kids that, yeah, some of them have like 2 millimeter microcarcinomas, right? And so it's important when you're grossing them to slice them thinly and submit them entirely, and don't load up the cassettes with lots of, because they're tiny, right? You can submit the entire thyroid sometimes in 2 cassettes, right? But you may not want to, because the more slices you put in a cassette, the harder it is for histology to embed them on the same plane, like as the wax is cooling, right? So maybe 2 slices, it's okay, just spread it out. And so then we'll have better ability to section through each of these tissue pieces and look for these microcarcinomas in these patients. So just attentiveness with grossing of these medullary prophylactics. I just wanted to put that word of caution.
And they're not super frequent. So the idea that if it's happening, that this one's probably going to know about it and she'll be on top of the gross. It's not like she's going to show up like, you didn't do what? She'll know about it. They're not super often.
Right, we'll hound you. So speak of the devil, and it shall appear. We, in this next case, have a microfollicular patterned neoplasm, perhaps with a thin capsule. And actually this is one of 3 slides from this patient, which we will get to, but because we're on the topic, all right, how about we talk, what's going on here? But let's talk about the other thing first, which is extremely subtle, but you may be able to see a very subtle increase in some cellularity in between these follicles here. And maybe some of these follicles look like they almost have multiple cell layers in them. And the cells that are forming these clusters, you sometimes can't really tell, are they thyroid follicular cells or are they something else? But these tiny little micro clusters, yeah, with a little bit of an eccentrically placed cytoplasm and some stippled chromatin, yeah. So these are C cells. So C cell hyperplasia, whether what cutoff you use or not, can be extraordinarily subtle, right? So if you want me to prove it to you, here's the calcitonin stain. And it's actually much more extensive than we were able to appreciate on H&E. But you can find probably that area where we actually saw the clusters, which is here. And then you can see these increase in C cells, but between and within the follicles. So, right, they exist also within follicles. So half of this follicle is lined by follicular cells, but then, oops, there's a C cell underneath it. There's a cluster in the stroma. There's a cluster here. And so, 50 per quote unquote low power field is actually not that many when you start counting it up. And like anywhere between, 6 and 10 in a cluster could also be considered C cell hyper. I mean, the definitions are kind of all over the place, but and the significance is arguably, questionable in a case like this. But this is background C cell hyperplasia. And so you can get C cell hyperplasia in the neoplastic setting, right? In these syndromic patients that is generally nodular, or you can get the C cell hyperplasia like this in patients who are maybe older, and patients sometimes who have hyperparathyroidism in the C cells hyperplays to kind of even out the calcium levels. But I report it if I see it. But usually I don't know that the clinical team actually has any effect unless there's some, suspicion for an underlying syndrome. And in most cases, like there's not, I don't know.
Yeah, I mean, a lot of times people report things that they don't know what to do with.
Right.
They really need your help, like all of your colleagues need your help. So if you actually give them information that they don't know how to handle, like, you typically, if you give them information, you also need to give them a little C note, this is how you handle it.
Yeah.
sir.
This is
Yeah.
how we do.
So that's kind of how you have to handle it. Like this, some of these findings can be very subtle. We don't really know the baseline level of C-cell hyperplasia because as Nicole mentioned, it's sometimes very difficult to see. And of course, as you all know, the C cells live in the superior 2/3 of the thyroid lobe. So you'd have to submit the entire 2/3 of every thyroid lobe and then stain them to be able to look for it to give you a baseline of how often this actually occurs in people, which we don't really know. But sometimes it looks funny and you pick it up, just your eye just picks it up and then you report it. And that's why it's like, oh, it can be seen in multinodular thyroid disease, it can be seen associated with an adenoma, it can be seen in all these settings. And it's like, it can be seen in any thyroid.
Mhm.
So, and what is clinical significance is actually unclear.
Another project.
Another project.
All right, it's 8:56. Should we finish? We can finish this one case here. So this slide, and this slide are all from the same patient. So we've already knocked out the C-cell hyperplasia, but can we knock out the actual primary reason for this patient's thyroidectomy?
Do we have invasion here?
Oh, do we? I mean, I think if you're gonna call something invasion, this is it.
Yep.
So I think the most subtle invasion was actually here that we probably just blew by on the C-cell hyperplasia. But like there's a little area of a capsule where stuff starts to sneak out, maybe on the opposite side of it. And then in this tip section, you can see these nice, very bulbous, kind of protuberant, right, nodules that are popping out from the edge of the nodule.
What does it tell you at this magnification? Because of
Mhm.
course, to make the diagnosis, you have
Oops.
to go closer and look more closely at the actual cells themselves.
Right.
So what does it actually tell you from this level, this power?
Carcinoma.
Tells you it's carcinoma. What type of carcinoma in terms of?
We need
Yeah.
to look if it's,
So this pattern of invasion, this nodular pattern of invasion, means it's a follicular type carcinoma. Now, whether or not you're going to call it a variant of papillary carcinoma, is going to be more closely at it. What it actually tells you at this power is this is a RAS mediated process that's going to be metastatic if it metastasized by bone, blood, brain, to the lungs, wherever it is, because this is not this.
The growth pattern of a PTC,
Yes,
right?
not the growth pattern of a classic papillary thyroid carcinoma.
Right. We're not even gonna look at the nuclei. Then just no.
Because
So-
it doesn't matter. Likely you are speculating about whether or not, and even if you were to dare make the diagnosis of follicular variant papillary carcinoma.
Nicole would kill you.
Nicole would kill you, but if she didn't kill you, it still would have a RAS mutation, and its pattern of metastasis would not be to lymph nodes. This is
Mhm.
not a tumor that would have positive lymph nodes, but this is a tumor that might possibly show up in the rib cage.
Mhm. Yep.
Also, on Monday, she handled that very well.
Oh, did you have?
So somebody suggested follicular variant of PTC.
like,
another thing.
I'm like, was she showing a follicular pattern lesion during the incident?
Really, anyhow.
No. So yes, a microfollicular patterned neoplasm with that amount of lobulated invasion, I don't even give a crap about the nuclei. And I think these are enlarged, they're cleared, fine, but they're really round. There's no pseudo inclusions, there's not overlapping. Like this is just it's follicular patterned, it's RAS mediated.
And
Exactly.
the other thing
Mhm.
it showed actually
Invasion.
is that some of them, there's a little bit of variability, there's a little bit of pleomorphism. So
Right.
some nuclei were bigger than others. This is a term we typically use called endocrine nuclear atypia. If
Mm.
you see endocrine nuclear atypia
Right.
in a follicular thyroid lesion, in some ways it excludes
Right.
papillary.
Right.
I mean, they have nuclear membrane like irregularities and intranuclear pseudo inclusions and grooves, et cetera. But when you start actually seeing larger and smaller nuclei, typically that pattern is all follicular tumors.
Right, totally. And so, right, so this was a follicular thyroid carcinoma that we perceived to not have angio invasion, only kind of this capsular bulbous invasion. So this would be regarded as quote unquote minimally invasive, right? So minimally invasive is only capsular invasion, no angio invasion, no extrathyroidal invasion, okay? So generally these are treated mostly with clinical observation alone and not necessarily any high dose radioactive iodine because the behavior is so indolent. I can't remember if did this have a molecular RAS? I think it did.
It did.
I think it had a, no, I mean, I know it does, but have we proven it? I think the FNA was RAS, yeah, because it had an interpace. It had
Oh.
or a firma or something.
And
And
the other
rest,
thing
yeah.
about this in terms of what you do in this case, it depends on the size of the tumor. So there's the guidelines from American Thyroid Association. If this tumor is 4 centimeters or less, you can, and no evidence of bilateral disease, and no evidence of lateral neck disease. And again, you wouldn't expect lateral neck disease in this type of follicular tumor. But if it's 4 centimeters or less, then they can follow by active surveillance, meaning you leave the other thyroid lobe in, and the patient doesn't typically need replacement hormone, and they can sort of move along with their life, and they'll follow up the patient by doing a scan of the neck every X amount of time. If the tumor is greater than 4 centimeters, then the indication is to actually do a contralateral completion thyroidectomy, which again is not necessarily indicated, but it is kind of the standard of care because, you know, these tumors, like I said, when they metastasize, they go remotely. They're not going to the contralateral side. Papillary thyroid carcinomas that are BRAF mediated oftentimes have multifocal disease. So despite the fact that they may be primarily in one lobe, they may also have small foci in the contralateral lobe. But again, it's based on what the clinical profile is of the patient.
Cool, thank you. The other thing I wanted to mention about this thyroid was the excellent way that it was grossed. And so you notice how these sections of tip, right, are submitted perpendicularly, and then these sections of the center are submitted crosswise. And so this is the way that these follicular patterned neoplasms should be grossed. And you can get a sense of what that is from the biopsy, right? If there's a biopsy in FNA that says, yeah, this is PTC, this is medullary, like you can serially section it the regular way, just totally crosswise, because a diagnosis of carcinoma has already been rendered and the chances that it will remain carcinoma are very high. However, if you get something like follicular neoplasm or FLUS or something like that, which implies this is a follicular pattern lesion, the only way I'm going to be able to tell whether it's carcinoma is by evaluating the periphery of the capsule, then you want to appropriately sample it. And so if this is your thyroid gland, and this is the underlying tumor right within it, for example, if it's really small, like a centimeter, you may not be able to do this technique. But if it gets any larger, like 2 centimeters, etc., you can lop off the tip and cut it in this perpendicular fashion, right? And then lop off this tip and cut it in this perpendicular fashion. And I don't mean the tip of the thyroid lobe, I mean the tip of the nodule, right? And so you want to it makes sense, right? You want to section this in the way that you would section a mucosal ellipse or a skinny ellipse or something, or a breast lumpectomy, right? Because of the orientation of the tissue on the slide. And you don't want to be looking, you don't want to be looking face on the tip of the nodule, right? Because you'll never see the invasion when it's coming at you, right? You need to see it on the slide coming through the capsule. So that's why we advocate grossing them in this kind of modified way. The point is to be able to see the invasion kind of through the tip. And I think these 2 tips demonstrate that quite nicely. Yes. Depends on whether you can detect where the poles of the nodule are before you section it, right? So if the nodule is sort of buried and you can't feel where it is, then yes, then you can bisect it longitudinally and see where the nodule begins and ends and do the tips from there. But if it's, for example, a nodule that's kind of expanding the entire lobe and you can know where it begins and ends, then you can just take extra, right, in that first and last section and just bisect it without quote unquote valving it first. Does that make sense? So the only reason to bisect it or bivalve it longitudinally is to see where the poles of the nodule are. If you can already determine that just based on the external exam, then you don't have to do it. Yeah, that's the only point of that method. Does that make sense to everyone? Okay.
We don't do that because it's too much to teach everybody. But
I like a
But that
challenge.
theoretically is like it is a much better approach to it. But that's the Cipriani approach. That's not used by no one else other than Cipriani, but it actually makes a great deal of sense. And is going to be the best view of the tumor. So that's great.
It's going.
No, I know the thing
just-
it's really a good approach. It's just not necessarily the standard
Right.
approach.
Right.
But
Um,
it's actually better for patients.
All right, it's 9:05. Should we keep going? Should we stop?
Yes, please.
Okay, if you guys don't have places to go, I don't either. Okay.
We do. but-
Oh, me too. All right, who's next? Who hasn't spoken in the past few days? Jasmine,
Okay, so already at this tower, we can see multiple lobbies of the form in the building, like this. Cellular. Here, maybe see some background, this is like that. But then, it almost, I mean, it has a regular border, I'm wondering if this is. Oh, yeah. This is vascular invasion, and when I was previewing this, I thought that this might have like, I mean, to me, this looks like a blood vessel, and this looks like an endothelial line.
Mhm,
So I'm very worried about.
Yep.
vascular invasion. But if you look at the actual morphology of the. So here, again, they do have like round nuclei, there is some like hypereosinophilic colloid, but it's not. There's not much of it, like normal thyroid with that.
right? It's just a sea of cells, right? It's like,
Yeah, it's very monotonous, but. Definitely way too.
Mhm.
Yeah, so that was I was definitely very concerned about vascular invasion.
Awesome. So what would be your diagnosis or differential diagnosis then?
So then I would be follicular carcinoma.
Okay.
vascular invasion.
Mm-hmm.
And I know we talked about this before, and sometimes it can be kind of hard to tell, but I thought that I was pretty convinced.
Yeah,
But when it's subtle, it can be really fun.
yeah,
And I think we talked about like looking at like fibrin clots or like
Mhm,
reaction
mhm,
to
mm-hmm.
like cells in blood vessels.
Right.
to see if it's- Try and make sure that it's real vascular invasion.
Right. Right, right.
Here it's like kind of out almost.
Yeah, which is exactly where you expect to find vascular invasion. Exactly. So,
Question
yeah.
about the fibrin plots.
Uh-huh.
Where would you look? It would not be within the tumor, right?
it would be at the edge of the tumor kind of a vascular wall interface. And so the one thing, so yes, we'll get into more detail about the actual tumor diagnosis, but if you see angioinvasion, yes, it's a carcinoma and it's an angioinvasive carcinoma. And so what in this case, well, you actually have a muscular wall, right? You actually have a muscular wall that is essentially completely, if you follow it, it is completely circumferentially around this tumor, right? So I don't know how else it could have gotten there in this case. And it's endothelialized. And if you are looking for fibrin thrombi or fibrous adherence to the vascular wall, you're going to kind of be looking in the interface between the tumor and the vascular wall. So yes, I believe we regarded this as angioinvasion. I didn't do any additional confirmatory like CD31 or anything, because I mean, it's basically, it's within the vessel, it's completely endothelialized and it's like stuck and pushing on the wall. So I regarded this as angioinvasive. So we are at an angioinvasive carcinoma. Determining angioinvasion in a follicular pattern neoplasm, a RAS-based neoplasm, or even in a true PTC, it will predict that this could potentially metastasize to hematogenous sites, right? Bone, lung, liver, brain, etc. So it is always important to differentiate angioinvasion from lymphatic invasion. Lymphatic invasion in PTC is extremely common, and whether it's there or not, whether we report it or not, has effectively no effect on patient treatment. However, angioinvasion does, as it in follicular pattern neoplasms, it will prompt more aggressive therapy, even in smaller, right, under 4 centimeter things. You might get a lobectomy and radioactive iodine because now you're in a vessel and now you're going to get out of the box, right? So angioinvasion will change the treatment for follicular pattern neoplasms. So it is important to mention. The other thing I wanted to talk about in this case, and all these 3 slides, you know, I'll give you this link with the updates, but all these 3 slides were in the original, are all from the same tumor. And what Jasmine was talking about, which I wanted to get into, is the architecture and what could be worse, right? So whenever you make a diagnosis of a carcinoma, a PTC, an FTC, whatever, you always have to think to yourself, could it be worse, right? What's the next step? Because you don't want to miss a higher grade process that could be coming out of this, right? So we see essentially solid growth. And when I like to think about solid growth in thyroid kind of as like hepatocellular carcinoma, right? Where you can walk from one vessel to another and across multiple nuclei and not hit a lumen, right? So this is essentially solid or insular growth pattern. The other thing that we see here is maybe a mitosis. Okay, so just keep that in mind. So keep the solid growth in mind. Is that or is that just no? Sometimes mitoses can be hard to find in these things, but you kind of want to see the nice like jazz fingers. Is that one? Maybe that's one. Maybe that's one. Okay, so when you have this essentially solid or trabecular or so-called insular growth, right, with very little colloid, and now potentially mitoses, is this now just a follicular carcinoma, or do you have to worry about or what worse it could be? Like a poorly differentiated thyroid carcinoma, some variant of a high grade thyroid carcinoma. So if you're coming to USCAP and you come to the endocrine companion meeting and you want to learn more about high grade thyroid carcinomas, someone will be giving a lecture on that. I think moderated by someone else. Right?
That's correct.
Okay, so please come. It's on Sunday. Shameless plug. It's on, yeah, whatever the Sundays of USCAP. Yep. So now the understanding of quote unquote high grade thyroid neoplasms are essentially any thyroid carcinoma, right? Any thyroid carcinoma, it has to be carcinoma, that has some kind of either increased mitoses or some kind of necrosis. And the fine-tuned, you know, discriminators are, some of them fall into the so-called poorly diff from the Turin criteria, and some fall into the new criteria that are not Turin-based, but they are any thyroid carcinoma that has increased mitoses or necrosis are just high-grade differentiated thyroid carcinoma. So there's poorly diff and there's high-grade diff. The commonality is increased mitoses and necrosis. The differentiator of poorly diff is that these are, again, usually RAS-based processes, so usually coming out of like a follicular pattern neoplasm, a follicular carcinoma, right? And they have solid or insular or trabecular growth, and they have increased mitoses or necrosis, right? So then you see a follicular pattern neoplasm that you think might be follicular carcinoma, you see the solid growth, you want to go around and you want to go look for the mitoses or the necrosis, and you may find them. So in this case, you'd be looking, what is the cutoff? Do you guys remember the three per 10, which is now 2 millimeters squared, right? So if you remember, the entire WHO is transitioning from high power fields to millimeters squared to even the playing field between different microscopes. So you now have to understand the field diameter of your microscope.
Which we do not.
Which we do, but you can, if you go to your Olympus manual online, you can find it and calculate it.
We're not going.
Very mega.
I'm just saying, I'm telling you why they're changing.
That's
What?
right, exactly. We've moved to high power fields. It's become 2 millimeters.
Yeah, no, I know 10x is 2 millimeters, but you need 2 millimeters squared. So you need what, 10x's? It's 2.2, exactly. No, I know, but it's like, if you have some weird ass microscope that's like bigger or long, you know, it's
just
you only have to do it once for your microscope.
Thing to be important. It's annoying. We are not doing math.
I'm just saying,
Do it once for your microscope and put it in your office.
just like cutting the tips of the thyroid longitudinally is the best way,
It's
so
the
is
best
this. It may not be the most practical.
But it's practical, it's only one.
It's only.
It's only one. It's only going to use one microscope.
No, you don't use one.
No. One area of 2 millimeters squared, which is basically 8 to 10 high power fields, depending on your microscope.
Yeah,
I'm just saying, or 12. All right, so then you want to look for
Borderline lesions are gonna be complicated.
borderline lesions. Oh, there was one. Oh, there's one. I was like, where is it? All right, we have, I think we ended up having more than 3 per 10 in this one, but it's so this is poorly diff, okay?
Okay.
Okay. Yes, Alia.
If you have a virtual slide like this.
Oh, you measure it
with
with,
a microscope.
okay, so you measure it with it. You do a circle and
We
you
need a
get
Zoom bomber.
the area. So there are actually, I don't know that the Path Presenter one does it. It doesn't measure an area, but now the AI integrated tools, like even for example, on Philips or hopefully what we'll get in the future, has a circle that you draw and gives you an area, or you can say, draw me a 2 millimeter squared circle, and it draws it, and then you look within the circle.
That's so nice.
Mhm. Mhm.
That would be nice in 15 years.
When you're ready to retire.
When you're ready to retire in 50 more years. Yeah, so if you don't have solid growth, right? And you just have a follicular carcinoma, this is probably angioinvasion as well, and you just have a follicular carcinoma, then you are looking for still increased mitoses and still necrosis. Strangely enough, because the validation studies for, yeah, that's angioinvasion, for not poorly diff, not solid growth, just follicular growth, the validation studies for that actually were 5 mitoses per 10 high power fields. So technically, if you don't have solid growth, if you just have follicular patterned growth, you require 5 mitoses to be high grade or necrosis. Necrosis always counts. I know, right? It's wonky, but these were the validation studies that were done. And so now that someone published this paper to validate it, like this is what we have to use. So technically, that's like a cross-shaped mitosis.
That's easy.
Technically.
That's fine.
Of
Someone found Jesus.
course, I found Jesus. I found Jesus. All right, so sorry. So yeah, so technically it's 5 mitoses per 10 high power fields or necrosis, but not FNA related necrosis with hemosider and histiocytes, whatever. This is like true, sort of punctate tumor necrosis with viable cells and karyorectic debris surrounding the necrosis. This particular case did not have necrosis, it just had mitoses. So that's how we got to ploidiv.
Like on the right, it looks purpley, and then on the left, it looks
Mm.
black.
Yeah, it kind of has an onco, I would argue, yes, it has increased cytoplasm.
Okay.
It doesn't have the nuclei with the prominent nucleoli like Herthel does, but yeah, it's approaching that, yeah.
Okay.
Does it really matter? You have widely based.
I know, but it looks.
Does it really matter if you now call it?
Oncocytic or non-oncocytic?
Oh, fully differentiated, like.
Oh, yeah, because technically, if you match poorly diff to other folliculars, theoretically, they do worse. And they may have underlying like TERT promoter, again, which is gonna make them do worse. Do you agree with this or no? Like if you have a widely invasive follicular versus a poorly diff,
If you have a widely invasive
probably
follicular,
bad.
it's much more likely to have additional mutations.
anyway, even if the morphology is poorly
I'm saying, it's like, it ends up matching the grading system, right? It's sort of, that's the whole thing with like even the high grade, they have to have a new system for grading medullary carcinomas. It's like, it's obvious when you look at the tumor.
Right.
Without having to say,
Right.
oh, it has greater than
Right.
X, and it is much more likely to
Right.
do.
Yeah, because the previous one, it's a widely invasive.
Right.
You can see
Yes.
how
Right.
widely invasive it
This
is.
is widely invasive in a
Like,
situation where you have
Why do you
giant
think-
vessels plugged,
Ah,
the likelihood of it
that's
metastasizing.
why is adding poorly diff to an already
Exactly.
angioinvasive, widely invasive follicular carcinoma
Because people
necessary?
need promotions.
People need promotion.
Okay, good. We use exactly.
We
I
do
mean,
not
I
use
would-
P53 staining
I would-
because
If I had the,
it is not, we use morphology rather than mutational status to make a diagnosis.
she is.
Correct.
It's gonna
Are you
happen.
gonna talk about high grade differentiated as well?
No,
Yeah, so high grade differentiated is the 5 mitoses per 10 high power field or necrosis with or without don't need solid growth. So you can have a baseline of a papillary carcinoma, you could have a baseline of a follicular carcinoma, but technically if you have 5 per 10 or necrosis, you can call it a high grade diff. Yeah.
Can you tell me, did that other one with widely invasive thing, did it have TERT?
This one?
Yeah.
I don't know if we have the results on it yet. This was a relatively new case, recent case, I think. It probably does. And do you know when I can essentially almost nearly 100% tell you that it will have TERT is if it has necrosis. Pretty much uniformly, if it's has necrosis, it has TERT and RAS. And if it has poorly diff features like this, it probably also has TERT, even if it doesn't have necrosis, but probably it does.
This one does have turn.
Exactly.
But that's the caveat to that is that when you see something like this, it probably does.
Mhm.
But the caveat to it, which is horrible, is that you actually you can have well circumscribed tumors.
Yes, that have
also
TERT.
have TERT. And so
Yeah, non-invasive, right?
yes, non-invasive. So the presence of TERT in a high-grade tumor is a bad prognostic sign.
Right.
But the presence of TERT in a low-grade tumor
It
makes you really, really nervous, but does nothing
is with or without RAS?
with RAS.
With RAS.
I've seen it also without.
I
Yeah,
suppose,
we
it's been
had-
without, but
We had cases without
This one
RAS.
had NRAS.
And TERT.
see, I had a case not too long ago that the patient had a lesion that had RAS and TERT, and so the surgeon actually did a bilateral prophylactic neck dissection. Did not send it for the section, she's like, it's overtly cancer,
Section.
bilateral,
What the
and
hell?
they're all negative. All the lymph nodes were negative and it was.
It's not even cancer. Mm-hmm.
I mean, we did have heard with.
Yeah. Uh-huh.
We know that.
Yeah.
But, if it's like this, and they usually know by just looking on imaging.
Yeah.
This is really bad.
Mm-hmm.
Yeah.
It's not like.
This
they
is
don't-
one they probably knew by imaging was cancer.
Mm-hmm.
Therefore.
Therefore, what's the problem? Exactly.
I
Okay. Let's
mean,
do.
would I do damage to the patient if I just called it follicular carcinoma, angioimmunity follicular carcinoma versus?
No.
Why not? They
No.
still treat it aggressively. They still do mutations, but you know, if
You could just write lesion, possibly aggressive.
you'd go like, this would be your answer. Okay,
Sorry, I'm just
we can
having-
keep going. Who wants to go next? Did you just volunteer, Perry?
Oh, no, I was thinking I have to go to.
Oh, you have to go. Okay.
Um,
Oh, thank you.
Mary, you just volunteered? No, actually, I was announcing my leaving. You're blocking me.
So in this section, we can see some peripheral normal thyroid tissue.
thank you so much.
Oh.
I did not have to go.
I'll give you back your computer to somebody. Okay.
She's gonna make that. It'll be
Oh, okay. Okay. I'm
And then
sorry.
there is this kind of a well circumscribed nodule. At least it looks well circumscribed on this part.
Mm-hmm. Mm-hmm.
So, but there are these large areas. of maybe like in function or something that could be prior FNA, or maybe there is like the Roman hallucination. There's some preserved cellularity at the periphery of the nodule. Which way to go.
I know, it's confusing.
And so how this-
I know, right? I have the same problem.
So these cells are mostly arranged in vaguely follicular and maybe trabecular pattern. But overall, the nuclei look bland, like they are mostly round, there is no overcrowding, they have like granular chromatin with this abundant eosinophilic granular cytoplasm. And there is background, I think there is like richly vascular background in the lesion. So I just thought maybe it is like further cell adenoma. Like further cell neoplasm favoring the benign adenoma, because I didn't see any invasion anywhere.
Yeah. So the thing I just wanted to point out here was sometimes these follicular neoplasms, even papillary carcinomas, right, can have extensive stromal change, let's say. And so in this case, it can make it somewhat hard for diagnosis, but as you correctly identified on low power, right, this is extremely well circumscribed. It's kind of a microfollicular pattern thing. And I always worry with this amount of stromal sclerosis because you can have this amount of stromal sclerosis in like invasive PTCs where the cells are very few and far between. But in this case, you have follicular type of cells with relatively bland looking nuclei. And
But then
so,
you also have this like little pointy area to
Mhm.
kind of penetrate a little bit into the capsule. And pathologists get really freaked out about that. Like what's true capsular invasion and especially in this particular case where you can see the likelihood is there's a biopsy site change. So one of the descriptions of these cells where they had, prominent granular cytoplasm, which means that they're mitochondria rich. And cells that are mitochondria rich tend to respond very negatively toward penetration. So if you take a needle and put it in there, you have lots of necrosis. So you see lots of intralesional fibrosis. You can see hemosiderin deposition sometimes. You see edema, but that's why you see all this sort of central stuff. But then you're having the irregularity from the fibrosis starts making
Right.
you worried about, is this cancer? Because it's a little bit irregular. Here's a little bit of tumor kind of climbing a little bit into the capsule. What does that actually mean? And people are always afraid to undercall. So you
Right.
start seeing a lot of overcalling, but you can actually give a descriptive findings, especially because they might see some of these changes radiologically as well. You can give some descriptive findings in a note if you feel uncomfortable, but it's still should call it benign.
yeah, I'm pretty sure we called this benign.
But we see lots of these cases
Yeah.
come from outside and people are calling them.
Right. Carcinomas, because they see this little
Carcinomas,
funky
yeah.
thing in the capsule and then are like, oh, it's invasion. Yeah.
Yes.
And in this case, the stromal change arguably is more of a collagenous kind of sclerotic fibrosis. But can you just go to the next, since you've got it, can you go to the next slide? And see the difference?
Was it oncocytic in the last case?
We can go back and check. I don't remember if I called it oncocytic.
Was
But-
this one related to like FNA, the whole thing died?
This one, yes.
I didn't blame on FNA.
No, this was a case.
Maybe you blame cytology.
This was a case of a woman who had I don't know if it was this case, but we've seen these completely infarcted nodules, and you can even see ghosts of cells, right? Completely infarcted, where the patient gets an FNA, and then like 2 days later, they call up Sarni and are like, oh my God, I have excruciating pain in my neck because their frickin' thyroid just infarcted, right? Like literally this person calls up with extreme acute pain because of this infarction. And so then they took it out and there's like not a single viable cell left, right? But you assume that you can only assume based on the dead architecture that you see that as long as there's no invasion, it was some benign, probably oncocytic nodule on FNA. But yes, no, this was just directly related to FNA. Because the mitochondria don't like penetration.
They don't like penetration.
So that was all what I wanted to show you here. So in this case, I think I called it infarcted nodule, right? Like like I'm just like infarcted nodule, comma, see comment, no viable cells, benign, probably benign. Okay. And then the last two are also the same patient. If anybody else wants to take over, otherwise you can keep going.
I'll say that it-
Yeah, Janet. Oh, I forgot my coffee.
She's done a lot. Also, I wanna see how difficult this is to drive. Looks
Maybe everyone should
pretty
just get
miserable. The what?
hand a mouse pad with the mouse next to him.
I don't think it's the mouse pad's fault. I think it's just.
Yeah.
I think it's a connection between the,
this is
and the
very- this is
barcode and
not
everything.
was Very delayed.
it's delayed, yeah.
Okay, so rim of normal thyroid appears to be well circumscribed at low power. Definitely looks quite cellular. These nuclei, they look maybe a little more elongated, this power. I don't think it's quite follicular pattern looking, but when I was previewing this, the thought of like morular appearing came to mind.
Trabecular, yeah.
Trabecular,
Mhm.
it's a little higher power. again, the nuclei don't really look necessarily like PTC like. I guess that's helpful in distinguishing. Maybe there's like some amorphous or like island material.
Colloid, I think, yeah.
Should I go to the next one?
If you want, yeah, sure. I think it's all
Oh,
variations on the theme, yeah.
And again, I think this here again looks like there's appears to be a capsule. That looks like more normal thyroid on the right, and this looks like more like the lesion.
Yeah, it looks trabecular to me, the pattern.
Does that matter?
No, it's not.
No, it's not.
Yeah, but there were sort of areas like this where it was like it almost looked like a ball.
Glomeruloid or something, yeah.
So I thought of Cribriform morula is very something that came to mind.
Okay.
Hyalonizing trabecular tumor was on my differential because of the pattern.
When I did consider that as well, but I read that they usually have
PTC like nuclei, yes.
You are correct, they do.
Exactly.
They usually have nice pseudo inclusions.
Just adenomatous nodule, something like that.
So,
I mean, yeah, because I was reading like solid trabecular then
Mhm.
form.
yeah,
Yeah,
I
so
mean,
it's not PTC, right?
it's well encapsulated.
right,
So
right. So it's like if you consider the entire thing to be nodule, right, you have a mixture of follicular pattern, this trabecular pattern, your nuclei are variably round, sometimes elongated. But like, I mean, really, you know, you can spend hours trying to figure out if this is a hyalonizing trabecular tumor, but it's not because you essentially have follicular pattern elsewhere, right? You have to consider the whole thing together.
Okay.
You want to consider if it's so exactly, right? So don't think, because this isn't non-neoplastic thyroid, that is also neoplastic, right?
Yes.
Exactly. And, you know, thankfully, I've battered the PTC nuclei all like out of your head. And so you don't think that, you know, you all don't think that these nuclei are appropriate enough for PTC. And I think that's great. I think somebody would look at this and maybe consider like a NIFT-P if, you know, the nuclei in some areas were atypical enough.
Yeah, because there's no
Yep.
way that you would look at this at low power and see this distinct area and not say to yourself, there is a clonal population of cells that look different than the surroundings. So I know that, like, for instance, I have at least 2 colleagues that would have to call this something.
Right.
There's no way. But if I had a situation like this, you know, I would, the strongest differential I would come up with is hyalonizing trabecular tumor. Given the pattern of growth, given the sort of mild pleomorphism, some slightly elongation of some of the cells that are like mild. So that would be but given the context of the overall thing, I would end up calling this either follicular adenoma or adenomatous nodule with prominent, you know, with focal areas of trabecular growth and, you know, focal atypia. And that's it, but not taking it any further, and there would be no need to. But it does actually bring up the, you know, the first parathyroid case that we went through. I thought, you know, like everyone started thinking about paraganglioma, right, that area. It's just a parathyroid. You shouldn't have shamed me. Son of a bitch.
Son of a bitch. So this is why I love you, because we think so similarly. So was this the case? So this is terrible. So we got this case from Razvan Lapadat sent me this case, and his group was really concerned about it because they saw these nuclear features. Oh, this is the other case? Which is the one? Oh, this is the not Razvan case. The Razvan case was so similar.
Yeah.
This was a case that was called the infiltrative follicular variant of PTC by someone out in the community. Yes, that was this one. This wasn't the Lapadat case. There were 2 cases we had in 1 week that were like equally bogus.
Where is it infiltrated?
It's not at all.
You might see.
And I don't know if this person, so
Probably thought
Tanner,
that
zoom
part
out.
was
Yes,
the
so I
tumor.
wonder if they thought that these trabecular
Yes.
parts were the tumor and the follicular parts were not the tumor, and so that it was infiltrating into the follicular parts, but the follicular parts are just all
Also
still
not.
part of the tumor, right? So
They got
this was,
confused.
yeah, exactly. So I think that's why they called it this, but they called it the infiltrative follicular variant of PTC.
Yeah.
And
Those are
I
BRAF
didn't
mutated.
understand what was going on
Yeah.
because it's benign.
Right.
Okay.
Yeah,
And those are
the infiltrative variant, follicular variant of of papillary thyroid carcinoma is BRAF positive. Those are typically not circumscribed, but they have follicular pattern and they infiltrate the adjacent thyroid.
Are we doing molecular on this? Yeah, we're waiting, right? Yeah, I mean, it was BRAF negative by IHC, so
IHC.
obviously. But there were 2 cases in the same like week, and
It's like kind of the same thing.
I think that's the same thing. So I think they
Yeah,
thought this
they
was
thought that,
infiltration,
because
but
they
we
thought those
think
were-
it's part of the
Yeah, because
whole
like
thing. Like you have to
Right.
consider it.
It's part of the whole. thing.
Yes, exactly, right? Because you can see the capsule, right? You can see the periphery. And then Razvan sent this case
Yeah.
that like he sent to an expert pathologist out in the world. And it got a very interesting differential. I'll show it to you. I'll show it to you. But yeah, it's all just benign. It's either benign or malignant, and this is benign. So thank you, guys. This was the last case. Do you guys have comments or questions? I hope it was helpful.
Really helpful, really fun.
And even if it wasn't helpful, we hope it was hopefully enjoyable.
Hopefully infiltrative.
Well, it was both helpful and enjoyable.
Awesome.
Yes.
Yeah, stop. And I think you have to go to, there you go. Go to,
Yeah, and
it's in the ellipsis. Mhm.
we call it non-invasive follicular neoplasm.
Oh, nobody